Today in person. Why don't we begin with brief introductions from each of you, just so the room can know who you are.
Well, that was an amazing performance, incredibly talented, and I think so telling for the 2.5 years that we've all been through this together. I'm Dr. Mo, the chair of medicine for the TCU School of Medicine, and I'm a practicing cardiologist here in Fort Worth.
Thank you. Definitely, that was a great experience for you guys to bring so many voices here today to share with us. So I'm Claudia Perez, and I am a neurointensivist at Harris downtown, and one of the professors at the TCU Medical School.
I enjoyed it very much as well, particularly the part at the end where you all were talking as physicians. I've had those very same conversations myself lately. I'm Susie Whitworth. I'm one of the pediatric infectious diseases physicians at Cook Children's.
Hello, I'm Glenda Daniels, and I'm on faculty in the nursing school. And I want to say again, you all were amazing. And just about everything you talked about, parts of it has touched my life. So I really thought you captured everything. So you guys are amazing. So keep it up.
So the first question that I would like to pose to our illustrious panel is this, which you kind of started to do this already, but there were so many different points of view that were shared. And what were some of the things that stayed with you as those who are in the medical profession? Just what has stuck with you after hearing these various pieces? In any order you would like to go.
You know, so much of this has stuck with me. I think one of the bigger things that has stuck with me in the Children's Hospital is seeing children or teenagers, and we've had this happen too many times, where the teenager is in the hospital and the parents are also in the hospital across the street at Harris or down the street at Baylor All Saints. And the child is alone in the hospital because the parents are sick. One at home, one in the hospital, or one's died and one in the hospital. And I think those really horror stories have weighed on me, I think, the most heavily mentally since this started.
Yeah, I think equally for me, I'm a neurologist. I'm mainly in the ICU, and just kind of being in the ICU and seeing how much this had affected patients, and seeing kind of the suffering that you're seeing day to day, and then stepping out of the hospital and having conversations with people who haven't seen it, and understanding that unless you're living it, unless you're seeing it, it's really hard to understand the why. And I think, one of the things that I've tried to do or strive to do is kind of try to explain the why, and just kind of understand the perspective of those who aren't there.
I just want to add that as healthcare professionals, we always want to use the best evidence that's out there. So I know it's frustrating sometimes when you hear different things, but we're trying to use the best evidence and keep up with the science that's happening. So this is a new virus, so having to deal with that is another thing that has been frustrating for people in the community. The other thing that me personally, I take students into the hospital, and it's their first clinical experience that I'm with them. So last spring was very emotional because I'm at the end of my career, and these are like 19-year-olds, and they're in the hospital. We're wearing masks. It's their first experience. They're going to be doing things with their patients, but we want them to stay safe, and we want the patients to be safe. And we made it through, but the vaccines were not available for them until like 3 months after they were in the hospital. But we were safe, and I think the CDC has those guidelines, and TCU's followed those, and we were able to make it through that semester. So I'm really happy for them. I'm sure it's an experience they'll remember for the rest of their lives. So
I think two immediate reflections on that very important question. One is highly personal for me and how I felt. December 17th, 2020, after almost 9 months of daily continuous care of patients suffering from COVID in our ICUs, managing risk in a practice for my patients, for my staff, my employees and myself, going home, disrobing in the garage, scrubbing thoroughly in the back, in the shower in the back of the house before I would have any contact with my family, and just waiting for that moment when I got an opportunity to take my first vaccine dose. I'll never forget that personal day for me, and the degree of comfort it brought for me as dad, potentially exposing his wife and children, the most important people in his life, to this virus that we were still struggling to learn about. Number two is the loneliness that this virus has created for so many millions of people around the world. You know, all of us as clinicians, especially caring for critically ill patients, know how crucial it is at the end of life to be surrounded and embraced by people that you've shared a life with. And to watch patients suffer in silence and lose their life in silence without their loved ones was very, very, very difficult for me as a physician. And my heart will always go out to all those families and then all those patients we've lost that went through that horrific tragedy, because no one sitting on this stage and no one sitting in this audience has ever been through this type of pandemic. And so that type of suffering was difficult.
Thank you all for sharing those thoughts with us. At this time, the floor is open to everyone for questions. Of course, I have some that I can get us started with, but a big impetus behind this event is to use art as a gateway to help us have important factual conversations about COVID-19 and vaccination, to be able to hear concerns that some may have, or positive experiences that you might would like to share. But for us to all be in this space together and at the end of the day walk away knowing that we got factual information. So are there any questions at this time? Yes.
Want me to do that one?
Yeah, I can add some scientific pieces to that too.
Good. They are all three, the Johnson & Johnson, the Pfizer, and Moderna vaccines, all are very effective vaccines. The Johnson & Johnson is not as highly recommended now by the CDC because there were some cases of thrombosis or blood clotting and strokes in women, in young women. Even that was pretty rare, but the effectiveness, Johnson & Johnson, Moderna, and Pfizer work very well. And between Pfizer and Moderna, I don't have a preference. I think that they are both they're about 95% effective. They're going to keep you out of the hospital and they're going to keep you from dying. I don't think there's much difference in their efficacy or in their side effects. Does that answer your question? Good.
Yeah, and I think I heard in a few of the monologues that I think the wonderful point of, gosh, these are brand new. They're so new. We know nothing of these new technology vaccines. But this is where it's so important for folks that have committed a career in science to really speak up and be heard. All of these technologies that we're seeing come to fruition in the pandemic that have now saved 2 to 3 million lives around the world, prevented maybe 10, 15 million hospitalizations, have been under development for over 20 years. Three things I want this entire group to reflect on in terms of why vaccines were able to come so quickly. So to those of us on the outside looking in, it looks like it was a one-year process, but this was a 20-year process in biomedicine. Number one, sequencing technologies. We can sequence things in a matter of hours now. From the time that this virus was isolated in Wuhan to the time that it was actually sequenced was a very, very brief period of time, and that was shared because we have a very collaborative environment in science to disseminate that information. Number two, we already had ideas as to how to develop these messenger RNA-based vaccines based on science that was already being conducted well in advance of the pandemic. And when labs come together and cooperate and communicate in a facile manner and share data in a setting like this, discovery is really sped up. So a lot of these techniques are very well established, well ironed out, and had been going on in biomedicine for a number of years. And then finally, when you're in a pandemic, and certainly all of us understand the challenges in terms of deploying a clinical trial and recruiting enough potential individuals and subjects to participate in a randomized trial, but that was never an issue in a pandemic because the N, meaning the number of folks exposed to or infected, and the control population, the subject population, were so high that it was very easy to recruit quickly and recruit the numbers needed to power all phases of these trials. And so if you really look at it from the vantage point of the lens of scientific progress, discovery, technology, communication, cooperation, and just being able to do things quickly, this was a process that had been going on for years. We just happened to benefit from it in a very short time frame because of the pressing nature of the pandemic.
Yeah, and I'll add to that. You know, I've done neuroscience research before, and being part of medicine, you know, the way that kind of barriers to research kind of came down whenever, as a collective, internationally, we all had the same goal of trying to get this under control. It shows you how much we can do, you know, and how limited sometimes we are whenever we create barriers to not allow the sharing of ideas. And this is really a learning point for all of us, you know, of how much we could accomplish if we could just kind of move things forward the way we did this time. And for me, really a miracle in the way that we were able to get there so quickly, because we did have that research sitting there, and now we were actually able to activate it and get it going, and you're gonna do marketing, you're gonna do this, and everybody's kind of working stepwise on their part, but we're all working together. And so that was really an enlightening time for us. And so in medicine, we're super excited, and you know, we're just kind of like, yes, we're getting there, and then translating that to the public and kind of letting them see this part that they may not have seen. You know, how do we get that message across? I think that's really the part that we're trying to work at, is really for people to be as excited as we were whenever we just kind of saw all these curtains come down and everybody just said, you do this, you do that, you do this, and we're all in it together. It doesn't matter if you're in that lab and I'm in this lab. It's not about, you know, this publication or that publication. It's like, we just have to save people. So just get to it and get to work, and let's all do it together. So that, you know, going back to your point, it was just really this neat time to see that while we're still having to deal with everything else. I think that really gave us hope during that time.
I think one of the stories that I did some research into the manufacture of these vaccines because we all wanted to know how they do this so fast and how are they made, and looking into this and just some of the human interest part of this that I enjoyed. In the German lab in BioNTech, in January of the year that this began in China, the virus was sequenced and it was shared all over the world within a week. And the director of the German lab sat down with that sequence and worked on his computer and thought through which part of this sequence, which part of this spike protein is going to work for a vaccine. Because messenger RNA technology is 20 years old or 30 years old. And it's been investigated for cancer vaccines and HIV vaccines and all kinds of other things. The technology is there, and actually the machines are laying around in people's labs. And the doctor that was there doing this research in Germany developed these sequences overnight or over a weekend, and he told everybody that worked in his lab, nobody's going on vacation, nobody's taking a day off, nobody's getting on public transportation. I can't have any of you all get sick. It is full speed ahead. And that just goes on to the story that you were saying. Dr. Wiseman probably would have told that story if he were still here, but I think it was that kind of mentality. We've got to save the world mentality amongst the basic scientists who were doing this research. And in many ways they did.
And just to add one other thing, when she was talking about messenger RNA and you were asking about Moderna, it's made the same exact technology as the Pfizer. J&J is a little different. I don't know, you might want to speak to that, but Pfizer and Moderna is the exact same technology.
So the J&J vaccine is based on what we call adenoviral vector technology. So it's a replication incompetent adenovirus that we've been using in MMR vaccines, all kinds of vaccines for 20 plus years. And there's a segment of, when we do give folks a diversity of choice, there's some folks based on the information that they've acquired, speaking to their personal physicians, talking to colleagues, friends, wherever folks get their information from, will feel more comfortable with something that has in fact been present and used in prior vaccine administrations. But in terms of efficacy, spot on. I mean, they're all certainly better than nothing, and every single one of them has a very strong effectiveness rate against something else that was brought up in the monologue, which is, death and hospitalization. These vaccines were never really intended to be, completely protective from infection. Really, the goal and the hope and the desire was, we're going to try to keep you from really, really getting sick and landing in the hospital and dying. And they've been really effective in the real world at accomplishing that.
Thank you so much for that insight. Very important for many folks to hear and to understand. Yes, as you guys pointed out in some of the monologues and short plays, it was mentioned, it was developed so fast. So it's really fascinating to hear from all of you that this is really the result of years and years of research. And on that note, I feel it is only appropriate that we take a moment to thank, through applause, our healthcare professionals for being on the front lines and really doing the work to help protect us. To help protect us and keep us safe. We want you to know that we are so appreciative for the work that each and every one of you are doing and your colleagues across the field of medicine and science. So yes, absolutely.
You will hear about a dozen opinions on that from a dozen really smart people. I don't think that is settled science, and I am not sure that it matters that much. It's effective to get a full vaccine series and a booster. I don't really feel like there's much difference in what you boost with or what you don't boost with. I got 3 Pfizers. My son got 3 Modernas. I think my mother got 3 Modernas. My daughter got a J&J and then a messenger RNA Pfizer. Does that answer your question? Meaning there's not really a good answer to your question.
Other questions from the floor? Yes.
Never had that pressure to say that. We did research on the admissions that we had during the Delta surge and during the Omicron surge, because there's not a conspiracy theory. I know if a child comes in with a ruptured appendix, that they're there for a ruptured appendix, whether they have COVID in their nose or not. There's not a conspiracy to call a ruptured appendix COVID or deaths. During the Delta wave, our own hospital research showed that about 2/3 of the patients that were there with COVID were sick with COVID pneumonia and COVID-related disease. The other third were there for car wrecks, ruptured appendix, dog bite, whatever. So it was about 2/3 COVID, 1/3 not COVID of all the positive COVID admissions. And then during Omicron, the Omicron admission stack was a little bit different. Half the patients that were there with half the patients that were there with COVID positivity were there because they were sick with COVID. The other half were there for the ruptured appendix, the dog bite, the car wreck, the other things. So it was about half and half. I'm not aware of anybody that's been pressured to lie about that.
Yeah, and I'll speak a little bit to kind of, my experience being in the ICU and having had patients pass away, and having dealt with families who were very concerned that, their family would be reported to have passed away from COVID if they had come in for a big stroke or head bleed and happened to have COVID. At the end of the day, the death certification that we do when somebody passes away, that's a legal document that is searchable and findable. And I would let them know that unless I felt that it contributed to their passing, it wasn't going to go on there. If you pass away from a stroke that's large and that's what you pass from, and you just happen to have COVID, that doesn't necessarily go on there. If you're somebody who didn't have any other risk factor, and that's the only reason that we could tell that you would have had a stroke, you still passed away from a stroke, and we would have considered COVID a contribution. So this is where there was a lot of misinformation, where this was getting out to the public. Never did I feel like somebody was asking me to put something on there that wasn't correct. And, we talked a lot with families about what was going on medically with the patient. And so once that certification was done, they could always go and check that. That's something that is there for them and is released to them.
From an overall biostatistical perspective, the error in terms of likelihood across the globe is not an over-reporting of cases. It's quite likely a vast under-reporting of actual fully realized cases of COVID. And so that's one thing that's being bared out in a lot of post hoc analysis of data sets around the entire world in the epidemiology community. And the second piece is, for all of us as physicians that are signing death certificates and then ultimately submitting final diagnoses in a discharge document, falsification of a medical record and then the attendant fines that follow and risk of criminal prosecution, Department of Justice action, et cetera, are so severe that everyone has learned this from the very beginning. Number one, we tell the truth because that's the right thing to do. Number two, pressure put on any physician to alter a document based on what we call a DRG code for reimbursement is simply not something that any of us would risk a medical license for. And that's I'd probably be speaking for just about every physician in this community. The risks are too high, and there's no reason to kind of work around this. The calculus is not there for those of us that are responsible ultimately for adjudicating that.
One other thing that has come to light that I will hear even from friends and acquaintances, people will say that this is overblown and that every time somebody went to the hospital they were calling it a COVID death, and there really isn't that much COVID disease. One hard fact that I have found convincing is when you look at the United States, year after year after year, there's actuarial data about who dies, how many car wrecks, how many breast cancers, how many suicides, how many murders, those numbers are fairly consistent through the last 20 years. And you have that number that goes along, and then you reach 2020 and 2021. And those numbers of just total deaths in the country soared. And they actually went up more than the number of COVID deaths that were declared. And that's what you're getting to with the underreporting. Perhaps we are saying there are 500 COVID deaths. There could have been 700,000 COVID deaths instead of 500,000 COVID deaths. So I don't think there's been any over-reporting on any sort of national level about COVID deaths. I agree with Dr. Mo, this is underreporting.
Thank you for that. Okay. In the back, and then I'll come down this way. Yes?
You want me to do the variant?
Yeah.
Every other week, there is a CDC and IDSA update phone call, Zoom meeting that I try to attend virtually, and there was one today about the variant. So it's a very timely question. In the United States, the variant BA.2 is now about 75% of what we're living with. It's confusing, I think, to the general public how those numbers are attained. When you get a COVID test at CVS, the doctor's office, the health department, your nose is swabbed, and that is a yes or no, you have COVID. There's not any information about whether that is Delta, Omicron, ancestral strain, BA1, BA2. What happens is, nationally, there are selected labs and health departments that take a sampling of those specimens and they run them for their genetic code. So that lab sends information to the CDC every week that says we sampled 1,000, we found 500 BA2s and 500 Deltas. So that information is pooled with the CDC, and every week they come out with where we are. Where we are right now is that we're about 3/4 BA.2. There's no information that it is any more dangerous or more pathogenic than BA1 or Omicron. It may be more transmissible from person to person than the original Omicron is, and all of that is in the early stages of understanding.
You can go to Tarrant County's health website and get an up-to-date dashboard. It's a wonderful dashboard that Vinny and his team have put together. But you can see exactly where key statistics are. And one of the main things that we use in terms of helping understand policy in medical centers, practices, schools, et cetera, is what's our caseload per 100,000 folks in any given community. And right now, despite BA.2 being 75% prevalent across the United States, thank heavens here in this local community, this county, that number is below 15, which is the lowest it's been in the 2+ years of this pandemic, outside of the first 6 to 8 weeks of 2020, March beyond. So, we're always sweating bullets because we don't know what's around the corner. If we look at the United Kingdom data, there was a fair uptick in just about anything that was happening in the UK. We can see kind of mimic here in the United States, but knock on lots of wood around us. So far, in Tarrant County at least, things are kind of, we're holding the line.
I believe so. Emma, and then Quint, and were there any other? Okay, all right. Here, and then we'll come this way.
My question relates to the monologue that Michaela had, where her brother developed a heart condition, which is believed to be caused by the vaccine. I was wondering if you guys had seen this in any of your hospitals, experienced it, or had any more information about it.
I can probably take that one. So this is cardioimmunology, and so this is very important. It's a great question, and it's something that we're all concerned about. We were definitely concerned about it when our 14-year-old son had his opportunity to get his first dose last year. We definitely, as mom and dad, thought through this carefully. His direction was very clear. He was ready. The moment CDC's panel advised it, he was signed up at the Tom Thumb on Hewlin to get his vaccine. Same for our daughter. So they really drove their own decision-making with our support. But as dad practicing heart medicine and understanding the data in terms of what was happening with this cardiac condition that's called myocarditis,